Okay, so what I want to talk about is how we actually approach interpreting these coronary studies uh, for, uh, for stenosis and otherwise. And so there is a scoring system for this, and it's called CAD RADS, and the newest version of this is CAD RADS 2. So let me start with this question. So what vessel are we looking at? Yeah, so you're looking at the LAD. Any lesions?
Yeah.
Where is it? Yeah, so in the proximal LAD, we have a calcified plaque, okay? So it is causing a little bit, there's some impingement, a little bit on the lumen. Do you recommend another imaging study? If so, what for this patient? First of all, how much stenosis do we think this plaque is causing? I think it's less than, probably less than 25%, okay? Do you recommend another imaging study for this patient? Based on the results that we have on this study? Yes or no?
No.
No, no, you would not recommend another study. So coronary CT in this case with a less than 25% stenosis, if this is the only lesion, if this is the only abnormality, this patient does not require any other workup for coronary artery disease. What about this case? What vessel are we looking at? Yeah, so here we're looking at the RCA. Any lesions?
Yep.
Yes? So how much stenosis is there here?
Greater than 80%.
Yeah, but 80%, greater, maybe almost 90%, certainly greater than 70. So do you recommend an imaging study for this patient? Does this patient require further workup for their coronary artery disease?
Yes.
What study should they have? Yeah, so this patient you would probably send to cardiac cath. Okay, so what are we getting at here? So this patient has severe stenosis there in the right coronary artery. So what about this patient? Is there a lesion? Well, the arrow's pointing to it. How much stenosis? Yeah, about 50%. Maybe. Well, I wouldn't say 70. Maybe 50, maybe a little bit more. Right? Do you recommend another imaging study in this patient? And what should it be?
No.
Yeah, so you're talking about a stress test, so a functional imaging study for this patient, right? So you're following then the CAD RADS recommendation. So we'll talk about, what does all this mean? And one of the advantages of, all of these scoring systems is that it does tell you what the workup should be for the patient. So CAD RADS 2.0, this is the newest version of this. So what are the goals of this? To standardize reporting of coronary CTA, facilitate communication with referring physicians, and this is probably the most important thing as far as referring physicians are concerned. It's the suggestions for patient management, right? So, I don't know if you're doing lung rads or bi-rads or even, even for the liver, the most important thing is the actual score. The clinician doesn't want you to describe the lesion in any great detail. They want to know what the score is because that's going to determine the management. What are you going to do next for the patient? So in this scoring system, the things that are evaluated, so evaluate the stenosis, the most severe stenosis, so the score is going to be the score, the ultimate score is going to be the score for the most severe stenosis. There is some evaluation of the plaque burden, and then there are modifiers, and these modifiers that are added, if there's an ischemia evaluation, like with CT FFR, fractional flow reserve, if that has been done, you can add that. Or in some places where they do myocardial CT perfusion, you might add that information also. But we'll talk about a little bit about what all these modifiers are. Now, this is important. So a lot of this stuff, and I'll tell you in the things that I cover for this, going through the scoring system, what I want you to know. I'm not going to give you a case and ask you to score it with CAD RADS, but I'll tell you what I think you need to know because what would be fair exam questions. So this you need to know. The score as opposed, comparing that with the degrees of stenosis. So 0, no stenosis. 1 is minimal stenosis, that's less than 25%. Score of 2 is mild stenosis, 25 to 49%. Score of 3 is moderate stenosis, 50 to 69%. 4 is severe stenosis, 70 to 99%. And 5 means occluded vessel. This you should know, okay? Now, there's also an evaluation of the plaque burden, and these are used with these modifiers P1, P2, P3, P4, whether it's mild, moderate, extensive, very extensive. This I don't expect you to know, right? But this is put in your report when you are reporting the results of a cardiac CT. The easy way to assess this is to just look at your calcium score. So if your calcium score is between 1 and 100, then you give it a P1. If the calcium score is between 101 and 300, you give it a P2, etc. If you don't have a calcium score, you can actually look at all the segments of your coronary arteries and decide if they're involved with plaque. It's a very tedious process. Or you can do a visual assessment for the amount of plaque, another tedious process. The easiest thing to do is just look at the calcium score and to use that for this modifier. Again, you don't have to memorize this, but you should know that assessment of plaque is part of the scoring system. Okay? So per patient, the most clinically relevant lesion, the highest grade stenosis, that determines the ultimate score that you're going to be giving. We evaluate all vessels greater than 1.5 millimeters in diameter. Okay, then in your overall score, it'll be something between a 0 and a 5. And then these are the modifiers that you will add to the scoring system. So N means non-diagnostic, HRP means high-risk plaque, I means ischemia, S stent, G for graft, E for exception. So we'll talk about what all these modifiers mean as we get more into this. So what are these modifiers about? N, if it's a non-diagnostic study. So if there's motion and you can't evaluate a particular vessel, to the degree that you'd like to, then that's N, that's a non-diagnostic study. Unless there's a stenosis somewhere else greater than 50%. So let's say there's a 70% stenosis in the LAD and you have motion in the RCA, you would not grade the whole study as non-diagnostic. You would score it based on your most severe stenosis. Second modifier, high-risk plaque. We'll talk about what the features are, but you have to have greater than or equal to 2 high-risk features to be able to use the modifier high-risk plaque, saying that there is a high-risk plaque. Your third modifier is I, so that talks about ischemia, and we'll talk about what the criteria are to say that there is ischemia. Fourth modifier, S, if there's a stent anywhere, regardless of stenosis within the stent. G for graft, if there's a graft, so you do try to evaluate the graft. You don't evaluate the proximal portion of the bypass vessel because that's the part that is already diseased and bypassed by the graft. So if you have a graft that goes to the LAD, you evaluate the LAD distal to the graft, not proximal to the graft. And then the last modifier, E, for non-atherosclerotic coronary abnormalities, and we'll talk about what some of those might be when we get to that. So the modifier N for non-diagnostic study. That means that not all segments greater than 1.5 millimeters in diameter can be interpreted. You might have motion artifacts. You might have blooming artifacts from calcium. There might be other artifacts that impair your evaluation of the study. If you score the whole study as an N, then that's a non-diagnostic study, right? So you've said the study is non-diagnostic. However, if there is somewhere a stenosis greater than 50%, right, that would get a score of 3, right? If it's let's say between just slightly greater than that. N becomes the last modifier. So let's say you have a 50% stenosis, you give it a score of 3. There's some plaque, you give it a P2, and then if there are other vessels that you cannot evaluate, then you would give the N as the last modifier over here. So you are giving it a CAD RADS score of 3, so this is your CAD RADS score here, and your N is the last modifier. So it's not CAD RADS N. So if you say CAD RADS N, that means the entire study is non-diagnostic. Okay. Some examples of different types of calcification. Which of these is considered a feature of high-risk plaque? So we have a spotty calcification, that's this small dot-like calcification. We have a medium-sized calcification, that's this guy, and then we have coarse calcification. Which of these is considered a region of a feature of high-risk plaque?
Coarse.
Spotty, right. So small spotty calcification is considered a feature of high-risk plaque. So that's something that you need to know when you're interpreting coronary CT studies. Another feature of high-risk plaque, so we did talk about this a little bit already, the attenuation values. So what's the cutoff? 30, right. So if the attenuation is less than 30 Hounsfield units, right, that is also a feature of a high-risk plaque. So that's something else that you can also evaluate with coronary CT. So plaque calcification types, we've talked about these. You can have non-calcified plaque, no calcifications. Some calcified plaque, spotty calcification, coarse is the spotty calcification that is a feature of high-risk plaque. So these are features of high-risk plaque. Positive remodeling, low attenuation core, spotty calcification, napkin ring sign, we'll talk about what that means. Ulceration, if there's contrast within the plaque, inflammation around the plaque, hemorrhage around the plaque, these are all features of high-risk plaque. These first four are probably, these are things that you probably can't evaluate with CT. These are a little bit tougher. Okay? So to say it's a high-risk plaque when you're looking at these coronary studies, you must have greater than or equal to 2 high-risk features. So spotty calcification, napkin ring sign, and we'll talk about what that means. Positive remodeling, there's a little bit of dilatation of the vessel where the plaque is, and low attenuation core. So we'll talk about what each of these are. Spotty calcification, punctate calcifications within the plaque, napkin ring sign. If you have a low attenuation core and somewhat higher attenuation in the surrounding plaque, that's called a napkin ring sign. And so that is also a feature of a high-risk plaque. Positive remodeling. If you compare the diameter of the vessel where the plaque is compared to the diameter proximal and distal to the vessel, if it's dilated a little bit more where the plaque is, that's called positive remodeling. That is also a feature of high-risk plaque, if that ratio is greater than 1.1 compared to the proximal vessel. Low attenuation core. So if the value there is less than 30 Hounsfield units, that's another feature of a high-risk plaque. So spotty calcification, these tiny calcifications, feature of high-risk plaque. Napkin ring sign. So if you have this low attenuation core, when you look at this in cross-section, there's a low attenuation core here, and surrounding it, the plaque is somewhat higher in attenuation. That is called a napkin ring sign. That's also a feature of a high-risk plaque. So here's an example. There's some mild stenosis of the RCA, so that would get a score of 2. P2, comparing if you have the calcium score. And high-risk plaque, because we have the attenuation, let's say, is less than 30 Hounsfield units, but also there's positive remodeling here. You see the diameter of the vessel here is greater than the diameter of the vessel more proximal to the plaque. So that's positive remodeling. So since we have at least 2 features, then we can give this modifier an HPR, high-risk plaque modifier in this case. Okay? Here's an example of ulceration within a plaque. So it's kind of tough to see with coronary CT, but here's a plaque, here's ulceration within a plaque. This is also a feature of high-risk plaque. Now, if you have information on ischemia, there's this modifier I that you can use, and the information usually if we're doing CT is fractional flow reserve CT, and we'll talk about this a little bit probably in the next lecture. So if there is evidence of ischemia using fractional flow reserve CT, then the modifier is I+, meaning that there is evidence of ischemia. Your fractional flow reserve less than 0.75, less or equal to 0.75. If it's greater than 0.8, then that's negative for ischemia, so it's I-. And if it's in the equivocal range, then it's I+-. So that's how we use the I modifier if you have information for ischemia for that particular stenosis. The E modifier, this stands for exceptions. So these are non-atherosclerotic coronary abnormalities. So remember, in addition to looking for obstructive lesions, there might be other abnormalities of the coronary arteries besides atherosclerotic abnormalities that you might have. Coronary dissection, anomalous origin, aneurysms or pseudoaneurysms, coronary AV fistulas, extrinsic coronary artery compression, let's say a blood vessel is compressing the coronary arteries, AV malformations, any other causes. So a non-atherosclerotic significant coronary abnormality, that's what this modifier is an implication of. So what is the point of this is to determine the management and the workup for the patient. So if your CAD RADS score is from 0 to 2, okay, so 1 is a 1 to 24% stenosis, 2 is 25 to 49%. If the score is from 0 to 2, that is considered non-obstructive coronary artery disease. So that patient does not require further workup for evaluation of their coronary artery disease. If the score is a 3, between 50 to 69%, that is considered moderate stenosis, and that is considered potentially obstructive. So this patient, the recommendation is functional assessment, either CT fractional flow reserve or perfusion test, stress test, some functional evaluation to determine if this stenosis is physiologically significant. If the stenosis is from 70 to 99%, that is considered severe stenosis. Here we have obstructive disease. For A, if it's 1 or 2 vessels involved. For B, if you have 3 vessels, or if the left main coronary artery, and this is something that you should know, if stenosis in the left main is greater than 50%, that is a 4B lesion. So the left main is the exception in terms of stenosis. So for 4A stenosis, the recommendation is invasive coronary angiography or functional assessment. For 4B, it's invasive coronary angiography. And if you have occlusion of a vessel, if you have complete occlusion of a vessel, that's a grade 5. So the recommendation there is invasive coronary angiography or a viability study to see if you have complete occlusion of a vessel, is there, how much viable myocardium if they're supplied by that vessel? Because if it turns out that the patient has already had a significant infarct and there is not enough viable myocardium supplied by that vessel, then revascularization of the vessel may not be helpful for that particular patient. So this is how the scoring impacts the management. And this also is something that you should know because these are fair exam questions in terms of the management of the degree of obstruction in these cases, okay? All right, so we'll stop there for today and we will continue with this next week. Last time we were talking about the CAD RADS scoring system, and this I do expect you to know, these are fair exam questions. So these are the CAD RADS scores correlating with the degree of coronary artery stenosis. So 0 means absolutely no stenosis, so that patient does not require any further workup. A grade 1 or grade 2, whether it's 1 to 24 or 25 to 49, this is considered mild stenosis. Again, that patient is not going to require any further imaging workup. When we get to moderate stenosis, 50 to 69%, that's a score of a 3. And there, further evaluation is recommended, some functional evaluation, such as a stress test or other functional evaluation, looking for evidence of ischemia. And then if it's severe stenosis, greater than 70%, depending on whether it's 4A or 4B. So for 4A, there the recommendation is stress or invasive coronary angiography. If it's 4B, that's triple vessel disease or greater than 50% stenosis of the left main. So their invasive coronary angiography is recommended. So this you should know, as those would be fair exam questions. Now, I've also given you this as far as the scoring and the management considerations here. So this you can study on your own. So this is for stable chest pain, the CAD RADS scoring system and the management considerations. And also there is one for acute chest pain. So if a person presents in the emergency room with acute chest pain and you do a coronary CTA. So there are also instructions on how to score that and then the management recommendations for the scores on that study also. So a CAD RADS 0 means absolutely no coronary artery disease. So perfectly clean coronary arteries, nothing there, no plaques, no evidence, not even mild stenosis. If we get a CAD RADS 1, also we also evaluate the extent of plaque, so CAD RADS 1, a P1, minimal non-obstructive stenosis, 1 to 24%, mild plaque burden, and you might have some positive remodeling, but there's no significant stenosis here. CAD RADS 2, so here we have, again, non-obstructive stenosis, this is 25 to 49%. Here we have moderate plaque burden, so that would be a P2 score. So you can see the lesion over here, and you can see that the stenosis is less than 49%. Again, here, no other imaging is recommended for that patient. When we get to a CAD RADS 3, so here we have 50 to 69% stenosis. This person also has a mild plaque burden. So here you might consider that there is further evaluation, functional assessment here to look to see if this lesion is physiologically significant, and we'll talk about that in a little bit more detail in a few minutes. CAD RADS 4, so this is when you have stenosis 70 to 99%, might be single or two vessel disease. So here also further imaging with invasive coronary angiography or functional evaluation is recommended. And then a 4B is if you have triple vessel disease or if you have disease in the left main. So if it's triple, yes. What's the problem? What was that?
I think you might be muted.
The mic
Said he couldn't hear you.
Oh, are we muted?
Have we been muted the entire time?
Let's see.
I think you're muted, Dr. Mondin.
Yeah.
All
No,
of
no.
them unmute.
Yeah. So I was muted from the beginning. All right, so let's start that again. Okay, so we were talking about the CAD RADS scoring system, and what I was saying is that this is stuff that you need to know here, the scoring system, the degree of stenosis, and the recommendations. So 0 means absolutely no coronary lesions. There, no other workup is needed. Minimal stenosis, 1 to 24%, or mild stenosis, 25 to 49%. Here also, the patient does not require any further workup. Moderate stenosis, 50 to 69%. Here, the patient should go to either functional evaluation here is recommended, stress test, or some other functional evaluation to determine if the stenosis is physiologically significant. And then severe stenosis, if you have greater than 70%. So here, if it's 4A, you can do stress or invasive coronary angiography. And if it's 4B, then their invasive coronary angiography is recommended. Now, I've also given you this in table format where we have the recommendations for the scoring system for stable chest pain. And there's also a scoring system for acute chest pain if the patient presents in the emergency room with acute chest pain and you do coronary CTA. Then there is a CAD RADS scoring system with management recommendations for that also, and that you can study. So CAD RADS 0 means no plaque, no stenosis, so absolutely clean coronary arteries. CAD RADS 1, this patient has a mild plaque burden, so that's 1 to 24% stenosis. This patient has a little bit of positive remodeling, but there's no stenosis. So here, no other imaging is recommended for this patient's coronary artery disease. CAD RADS 2, again, it's non-obstructive, 25 to 49%. Here, there's a moderate plaque burden. Again, here, no other workup is recommended as far as for the coronary arteries themselves. When we get to CAD RADS 3, so here 50 to 69% stenosis, so now you can go on to functional assessment to determine if this lesion is physiologically significant. And then CAD RADS 4, here we have severe stenosis, 70 to 99%. So here you can consider invasive coronary angiography or functional evaluation to determine if the lesion is physiologically significant. If we have CAD RADS 4B, this is if we have triple vessel disease. So here invasive coronary angiography is recommended. And then another category for CAD RADS 4B is if there's greater than 50% stenosis of the left main coronary artery. So here invasive coronary angiography is also recommended for further evaluation here. If there's a total occlusion, that's a CAD RADS 5. So if there's complete occlusion of the coronary artery. So here you might consider invasive coronary angiography or functional or and viability testing. So viability testing to determine if there is how much viable myocardium is there in the territory of the obstructed vessel. So here if the vessel is completely obstructed, why do we still opacify the distal right coronary artery? We can still see the distal right coronary artery even though there's a complete obstruction here. So how does that occur? Yeah, so through collaterals. So as these obstructions become chronic, the patient develops collaterals, and so there you can still get opacification of the distal coronary artery, which you can see better on invasive coronary angiography. So they can see the collaterals and also how it opacifies in time, as they'll see that the vessel is opacifying through collateral vessels. So the overall scoring system will give a total score based on degree of stenosis, and then we have these modifiers that we've talked about. So we've discussed these already, whether there's high-risk plaque, whether there's evidence of ischemia, if there's a stent, if there's a graft, and then if there are non-atherosclerotic coronary abnormalities, then you would describe those also, but in the scoring system you would indicate that one is present with the E modifier. So if there's motion artifact, which makes the study non-diagnostic, then instead of giving a grade, then you would give it an N, a CAD RADS N, meaning it's non-diagnostic, which means that either you might have to repeat the study or or send the patient to some other type of evaluation. And the exception to that is if you do have a lesion that can be scored 3 or above, then you would give the patient that score, and if there are other vessels that you cannot evaluate, then you would use N as a modifier, but the first score, if it's 3 or above, you would indicate that, as because this is an actionable lesion, as the patient would need further evaluation anyway. Okay. If there's a stent, you would indicate that also. So we have S here indicating there's a stent. And sometimes you can't evaluate the degree of obstruction inside the stent if the stent is large enough. So we can do that. This patient has severe in-stent stenosis. So here we would send the patient for invasive coronary angiography. And if there are bypass grafts, then you would try to evaluate those too. This person has a Lima graft here to the LAD, and there are multiple saphenous vein grafts. You only have to evaluate the native vessel distal to the bypass graft. Obviously, there's going to be lots of disease proximal to that. That's why the patient was bypassed. So you only evaluate the vessel distal to the bypass graft. So this is an example of severe stenosis here in the right coronary artery. And then this patient also demonstrates positive remodeling as the coronary artery is a little bit dilated there where the stenosis is. And there's also a napkin ring sign. There's a cross-sectional view through the region of stenosis. You can see the low attenuation core surrounded by regions of higher attenuation. Okay. So that combination of positive remodeling and the napkin ring sign means we have 2 criteria. We filled 2 of the criteria for a high-risk lesion. And so that's why we would also employ the modifier in this case, HRP, indicating that there's a high-risk plaque in that particular case. Okay. This is the part, though, I think that you need to know for exams, so make sure you're familiar with that. Okay. Now, what do we mean by functional assessment? So this is an evaluation for ischemia. So it can be CT, FFR, and we'll talk about what that means. Some places are able to do CT perfusion studies, so that's also another way for evaluating for ischemia. Exercise stress test, stress echo, SPECT, PET, cardiac MRI, stress perfusion cardiac MRI, or invasive FFR if they happen to be doing invasive coronary angiography. They can also do FFR, invasive FFR, to evaluate for ischemia that way also. So these are all examples of functional assessment looking for ischemia. So if I ask you this question, which is better for evaluation of coronary artery disease? Is it coronary CTA, purely anatomical coronary CTA, where we're looking at the anatomy of the vessels itself, or is it just looking, or just strictly functional evaluation? And by that I mean stress test, nuclear medicine test, where we have stress and rest images looking for evidence of ischemia. So, at first, when you think about this and you think about, the amount of resolution and how well you can see the coronary arteries here, when we're looking at the coronary arteries directly, comparing that to functional evaluation when you get images like this that, can be difficult to interpret sometimes, it seems to be a no-brainer, right? That, looking at the coronary arteries directly, certainly that's going to be better than just looking at these kind of evaluations, looking, nuclear medicine study or stress test or echo stress or something like that. It turns out that that's not correct, and this was evidenced by this PROMISE trial. This was a prospective study where they compared coronary CTA with standard functional evaluation. So they compared the degree of stenosis you can assess on coronary CTA with functional evaluation, stress test, nuclear medicine test, echo stress, etc. So there were 10,000 subjects in this study, stable chest pain, who had suspected but undiagnosed coronary artery disease. They were randomly assigned to either coronary CTA or functional evaluation, median follow-up of 2 years, and then the treatment for those patients depended on the results of these studies. So endpoints, death, MI, unstable angina, major procedural complications, so some kind of cardiac event. The idea is the better test should have led to a better outcome. So if CT was better, then the outcome of those patients in this arm should have been better than the outcome of the patients in the arm that did functional evaluation. It turns out that when you look at the event rate, so as the graph is going up, here's time here on the horizontal axis. If you look at the cumulative events, there was no significant difference between anatomical testing, which is coronary CTA, versus functional evaluation. So in terms of the outcome of the patients, there really wasn't a significant difference. So the CTA patients had a lower rate of negative cardiac caths, which should not be surprising because when you do CTA, you're going to find all those cases that have no evidence of any kind of obstruction. So you're going to filter out those cases from going to coronary angiography. So that's not surprising. The CTA patients had a higher rate of invasive coronary angiography and revascularization without a reduction in events. So the patients who are getting CTA, more of those went on to invasive coronary angiography. So the interpretation of this was that CTA was finding stenosis that did not affect outcome, meaning false positive results. So, and this is one of the problems when you're doing a purely anatomic evaluation, when you're just looking at the coronary vessels, you might have a higher false positive rate. So CTA seemed to increase the use of downstream testing. And so this is why we get to fractional flow reserve, and we'll talk about this, is some evaluation of the physiologic significance of stenotic lesions to determine what should be done for those patients, rather than purely an anatomic evaluation of the stenosis as we see with coronary CTA. So fractional flow reserve is a physiologic evaluation of the stenosis, whereas just looking at the images on coronary CTA is a purely anatomic evaluation of the stenosis. So there's a difference between the anatomic evaluation of a stenotic lesion versus functional evaluation. So depiction of the anatomy alone, regardless of the quality of the image, is not enough to determine if the stenosis is physiologically significant. So there's a difference between an anatomic stenosis versus a hemodynamic stenosis. So there's a difference between an anatomic stenosis, what you see visually, versus a physiologically significant stenosis, meaning that all stenoses that we see visually based on the anatomy are not necessarily physiologically significant. So it's important to be able to differentiate the two so that you're sending the patients, so that the only patients you're sending to management are those patients that are actually going to require management of their stenosis. So this was a problem that was well known. So here, this is comparing the survival, so here's the survival curve, of patients who were getting medical therapy for coronary artery disease versus patients who were getting intervention, who were getting cardiac cath and then stenting or angioplasty of their stenosis. So it was known that in terms of long-term survival rates, that the invasive procedures did not make a difference in terms of the long-term survival of those patients versus just medical therapy for those patients who had coronary artery stenosis. So this was back in 2007. So not all stenoses are the same. So how do we find those that are really important to treat? This is where fractional flow reserve comes into play. So what we're doing here is that we're evaluating the physiologic significance of the stenosis itself. So how this is done invasively is there is a probe that is put here when they're doing coronary angiography. They could put the distal tip of the probe distal to the stenosis, and there's a pressure transducer in there that will measure the pressure. And then under the conditions of maximum vasodilation, the pressure here distal to the stenosis is compared to the pressure in the aorta. And that's considered abnormal if the ratio is less than 0.75. So that means that under the condition of maximum vasodilation, that this lesion is significantly physiologically obstructing the flow distally. So that's a physiologic measurement of the significance of the stenosis, and that's called fractional flow reserve. So this can be done during invasive coronary angiography to determine the hemodynamic significance of these specific lesions, and then those lesions that demonstrate hemodynamically significant stenosis, then those are the lesions that you would want to treat to try to improve perfusion to the myocardium that's supplied, that's distal to that area of stenosis. And so this measurement helps you to determine that. So if it's less than 0.75 to 0.8 using invasive coronary angiography, then that's an indication that that lesion can be a cause of ischemia. So what happens then when we use that as a guide to treat lesions? So using fractional flow reserve guided intervention versus just angiographically guided intervention when they're doing invasive coronary angiography. So here we're looking at survival on the y-axis compared to time on the x-axis here. So those patients where fractional flow reserve is used to guide therapy, they survive, the survival rate is better than those patients where just the angiographic appearance of the stenotic lesion is used to guide therapy. So using fractional flow reserve as a guide to decide what lesions require therapy results in better outcomes for these patients. So there's a difference between what looks like a stenosis angiographically versus what is a hemodynamically significant stenosis. So if we look at these cases where we have moderate stenosis and look at their fractional flow reserve, so here where we have patients who have 50 to 70% stenosis, 65% of them had a fractional flow reserve greater than 0.80. So these stenotic lesions, a high percentage of them, still had, these were not physiologically significant. Even here, when we get to 71 to 90% stenosis, about 20% of them had fractional flow reserves greater than 0.80. And then when you get to really severe stenosis, then here, the rate of the rate of significance of stenosis is much, much higher. So moderate stenosis by itself is a poor predictor of ischemia, and this is where using some physiological assessment is helpful in determining how to treat the patients. So in this particular study, fractional flow reserve guided PCI is better than medical therapy. So here is the incidence rate of cardiac events, and you could see here when patients have just medical therapy, that incidence rate is much higher than the incidence rate when the patients receive intervention, angiographically guided intervention based on the fractional flow reserve. So the rate of coronary of cardiac events is much lower when fractional flow reserve is used to guide the therapy that the patients receive. So what's the implication of this for cardiac CT? Well, it turns out that with coronary CT, there is a way to get these numbers for fractional flow reserve. And this involves right now it involves sending the data set out to an outside laboratory. And here they use complex computational models, modeling fluid dynamics on your coronary CT data set to actually calculate fractional flow reserve for the various vessels. And then the data comes back to you in terms of this color-coded analysis. Obviously, red is bad, okay? So it comes back to you in terms of this color-coded analysis, giving you an idea of what the fractional flow reserve is within these coronary arteries. So for CT, normal is considered if it's greater than 0.80, abnormal if it's less than 0.75. Borderline between 0.76 and 0.80, that's considered indeterminate. So this is CT fractional flow reserve. So the idea here is that if there is a stenosis that you see on your coronary CTA, you send that data set out for a fractional flow reserve evaluation, and there you look distal to the stenosis to see if the fractional flow reserve there is below your threshold value. And if it is, then that's an indication then that you have a physiologically significant stenosis. So this helps to improve the specificity of CT when fractional flow reserve is added when you have a lesion that you detect on your anatomic evaluation. So in the CAD RADS scoring system, this is, if this information is available, this is where you add the I modifier. So I positive, meaning that there is ischemia, means that your fractional flow reserve results were positive for ischemia. So that means your fractional flow reserve is less than 0.75. And on your color-coded images, that would come back as red. Okay. It's I negative, meaning there's no ischemia if the number is greater than 0.8. And it might be in the indeterminate range between 0.76 and 0.80, okay, which is that over here for this particular stenotic lesion here, and then this vessel over here. Right? Now, the important point when you're doing this is what you want to do is you want to evaluate the fractional flow reserve within 1 centimeter of a stenosis. So what you're doing is not evaluating the whole vessel. What you're really doing is evaluating the stenosis. So you look on your CT where the stenosis is, and you look at the fractional flow reserve of the vessel within 1 centimeter of that to determine if that stenosis is physiologically significant. So the distal tip of the vessel does not count. So this is how we apply this. So when you do a coronary CTA, if you find at least a moderate stenosis that you're concerned about, moderate or greater than moderate, you can send that data out for fractional flow reserve measurement, and then you find your stenosis on your fractional flow reserve data and look at the coronary artery distal to that to see where it falls in terms of the numbers. Is it a positive result, negative result, or is it an indeterminate result? And that's how we use fractional flow reserve. In this study, they did that. They did coronary CTA with fractional flow reserve versus traditional testing and looked at the outcomes. So, and that's called the precision pathway. And then here, if we look at the proportion of cardiac events, those patients who had coronary CTA and fractional flow reserve for lesions on the coronary CTA, and then had their management based on those results, you could see that the percentage of events, cardiac events for these patients was less than that group of patients that had traditional testing. So this does work in terms of improving the outcome for the patient. So coronary CTA with fractional flow reserve was better than traditional testing in terms of outcomes for these patients. Okay, so let's move on now. This is a 35-year-old woman with chest pain and elevated troponins who gets a coronary CTA. And we're looking at the LAD here, okay? So what abnormality do you see here when you look at the LAD in this patient? Well, does this part of it look okay? Yeah. What's happening here? Well, there's kind of a diffuse kind of stenosis there, right? We don't really see coronary artery disease in terms of calcifications or plaques, but we see this kind of decreased opacification and this kind of abrupt tapering. That's the way to describe this, an abrupt tapering of the vessel. And you can see here on your cross-sectional views, the vessel looks very fuzzy, and there's an abrupt tapering of the vessel. And around here, there's a little bit of increased attenuation, actually, of the fat directly around the vessel, okay? So in a young woman with this history who has these findings on CT, let me show you something else. So here we're looking at renal arteries, right? What's the finding in the renal arteries?
FMD.
Yeah, FMD, right. You see these irregular areas of irregularities, those irregular areas of dilatation. So what's the diagnosis for this patient? We're talking about her coronary arteries. What's going on here? Well, the term is not vasculitis. What do we call this?
Dissection.
Yeah, this is a spontaneous coronary artery dissection, okay? So this might start to show up on your exams. So if you get a history of a young woman, acute chest pain, no evidence of coronary artery disease, and these kind of strange findings on your coronary CTA, abrupt tapering of the vessel, abrupt narrowing of the vessel, this is spontaneous coronary artery dissection, or SCAD is the abbreviation for that. And in this particular example, you can see the abrupt tapering of the vessel and the increase in the attenuation of the fat around the vessel for this particular patient, okay? So this is dissection of a coronary artery not associated with coronary atherosclerosis or trauma. It's thought to affect 1 to 4% of patients presenting with acute coronary syndrome. It's a common cause of myocardial infarction in pregnancy and young middle-aged women. So if you get that history, pregnancy, young middle-aged woman, abrupt onset of chest pain, think about this, spontaneous coronary artery dissection. 90% of patients are women between the ages of 47 to 53. 45% of infarctions in pregnancies, right? 70% of patients who have this, pregnant or postpartum. 35% of myocardial infarctions in young women, less than 50 years of age. Up to 80% of these patients have fibromuscular dysplasia. So it is associated with FMD, fibromuscular dysplasia. So it's thought that the weakened media leads to dissection and downstream ischemia. The LAD more commonly affected than the circumflex than the RCA. So the LAD is the most common vessel affected by spontaneous coronary artery dissection. So the theories of this, how does this occur? We're from the inside out, tear in the intima, just like with the aorta, blood goes out, causes dissection. Another theory is that you get intramural hematoma that starts on the outside, and then because of some de novo disruption in the media, which then causes obstruction of the lumen. So not quite clear, but it does seem that all of these factors can be related to this, right? So sex hormones, emotional stress, pregnancy, connective tissue disorders, FMD especially, some relationship with hypertension. But when you get history in that demographic, young, middle-aged woman, pregnancy, chest pain, think about this, spontaneous coronary artery dissection. There is an angiographic classification for this. So the type where you actually see a dissection flap, like you might see when you're doing CTA of the aorta, right? This is what we look for when you do CTA of the aorta. This is what you might expect to see with a dissection. This is actually the minority. So 30% or less, you'll actually see a dissection flap. Most cases, you will have this kind of diffuse, smooth stenosis of the vessel on CT or on imaging when you have spontaneous coronary artery dissection. And then a smaller, very small percent will have a focal area of stenosis, okay? So in most cases, you'll have this kind of diffuse stenosis of the vessel. The actual dissection itself, to see the dissection flap, that's about 30% of the cases. So features of spontaneous coronary artery dissection and coronary CTA: luminal stenosis, intramural hematoma, dissection flap, we've said that that's 30% or less. Epicardial fat stranding, increased attenuation of the epicardial fat, tortuosity of the vessel, no plaque, no atherosclerotic, not much in the way of atherosclerotic disease, women less than 50 years of age. So here there's abrupt stenosis. Here you can actually see the dissection flap in a different patient, okay? So the primary CTA findings: abrupt luminal stenosis, tapered luminal stenosis, intramural hematoma, the dissection flap, less than 30%. Secondary coronary CTA findings: epicardial or perivascular fat stranding, myocardial hypoperfusion, coronary tortuosity, absence of coronary calcifications, ill-defined hyperattenuation adjacent to the coronary artery. If you've done a C- study, that's less common. There you're talking about intramural hematoma, okay? So with spontaneous coronary, in this example, you can see there's intramural hematoma here, adjacent to the vessel, here and here on the cross-sectional views, okay? So that's from spontaneous coronary artery dissection. So this is the example we saw earlier, where you can actually see the dissection flap in this case. And then here it is on the cross-sectional images. But realize this is going to be the minority of patients. So don't go looking for a dissection flap. Look for that abnormal stenosis or tapering of the vessel, which is going to be more common than to actually see a dissection flap. Now, having said that, if spontaneous coronary artery dissection is suspected in a patient, what's the recommended imaging for that patient?
Invasive angiography.
Yeah, invasive angiography is the recommended imaging, not coronary CT, although they might come across it on coronary CT. So invasive coronary angiography is the modality of choice for making the diagnosis. So let's say you have a patient with known fibromuscular dysplasia, a young woman who comes in with acute chest pain, elevated troponins. So they're suspecting, acute spontaneous coronary artery dissection. That patient should go to invasive coronary angiography. Usually the treatment is conservative. If the patient is hemodynamically stable, it tends to resolve on its own. CT can be used if recurrence is suspected. So if the patient has had a known dissection before, and if recurrence is suspected, recurrence can happen in up to 27% of patients at 5 years. So there is a significant rate of recurrence of dissection in these patients. With the discussion of ischemia and complications of ischemic heart disease. So one of the ways that you can study or look for ischemia with MRI is a myocardial first pass perfusion study. And what this involves is very rapid imaging through the heart. You can see here a series of short axis views. So it's really, this is speeded up. It doesn't go actually this fast. But the idea is contrast is injected, and then we look at the perfusion of the myocardium of the left ventricle, looking for perfusion defects between the resting and the stress condition to see if there's any reversible defects. Okay? So here's resting short axis view through the left ventricle. And then here we have the stress portion, and the stress is done with pharmacologic stress. So what's different between rest and stress?
On the stress images, there's no enhancement of the,
Yeah, so there's a perfusion defect, right? There's decreased enhancement along the anterior wall and septum, right? So that's in what vascular distribution?
LAD.
LAD, right. So your interpretation of this would be what? What's your conclusion?
Involving the LAD.
Yeah, so that the patient must have a tight stenosis of the LAD resulting in ischemia. And this is reversible, right? It's not there at rest. It only shows up under the stress condition. So here's another example. There's the rest, and here's the stress condition. So what's different this time?
There's circumferential involvement and it's subendocardial.
Right, so there's a subendocardial perfusion defect. Is this in more than one vascular distribution?
Yeah.
Yeah, it is. So this patient has multivessel disease, so that's more than one vascular distribution. And this is where MR can actually be better than nuclear medicine. If you have a symmetric ischemia in more than one vascular distribution, you can pick it up on MR. Might not be so easy to pick up when you're doing a nuclear medicine perfusion study. Okay, so what's really going on here is if you have a tight lesion, then you have the vessel distal to that that's supplying the myocardium. Under the resting condition, that is maximally vasodilated to maintain perfusion to the myocardium. If you have a normal vessel here with no obstruction, then it's not dilated. When we give the vasodilator or when the patient is stressed, then we have vasodilation here of the normal vessel, but the abnormal vessel is already maximally vasodilated. So what happens here is that perfusion increases here to the normal myocardium, but the perfusion is not able to increase here to the ischemic myocardium. And so under the stress condition, you will see a perfusion defect, which you will not see under the rest condition. So that's called a reversible perfusion defect, and that indicates that there's ischemia along the distribution of that vessel. And the vascular territories, so these you can judge based on your short axis views. So the idea is the same as with nuclear medicine in terms of where we look for these vascular distributions, the LAD anterior and septal, circumflex along the lateral wall, distal RCA or PDA along the posterior wall of the left ventricle. Okay? And then there is a segmentation model where the segments are numbered, whether you're at the base of the heart moving towards the apex. So this I don't expect you to memorize, but this segmentation model is what you would use if you're reporting your results. In your report, you'd want to localize the ischemia to the particular segments that are involved. Okay? So the basic idea under the rest condition, no perfusion defect. Under the stress condition, there is. So this is a reversible defect, meaning that there is going to be then ischemia in the distribution of the vessels supplying that portion of the myocardium. And then, as we said, when you have triple vessel disease or more than one vessel involved, this is where MRI can really be helpful in picking up these perfusion defects. All right, so let's talk about the next case. So what kind of views do we have here? This view is two-chamber view, this view is four-chamber view, and this view is a short axis view, right? So what kind of pulse sequence are we looking at?
SSFP.
Yes, this is SSFP, bright blood imaging. So here, what are some of the things that you can evaluate when you look at the myocardium? What are some of the things that you're going to be looking at? What do you look at?
Motion.
Motion, right? So before you get to that, you might look at chamber size, right? When you look at the chamber size, what do you notice?
Left ventricular hypertrophy.
Well, the size. Start with the size first. The left ventricle looks a little bit larger than it should be, right? Then you can look at the myocardial thickness. So there is some left ventricular hypertrophy here, okay? And then now you can look at wall motion, right? So when you look at wall motion, what do you notice?
The septal wall's hypokinetic.
Yeah, so you can see that we have wall motion here along the lateral wall and the posterior wall, but here along the anterior wall and along the septal wall, it's somewhat hypokinetic, okay? So what would you like to see now? Well, what could do this?
Perfusion.
Well, if we're going to go ahead and do a stress test, right? You'd want to see first pass, you want to see perfusion, but this person has this defect at rest, right? This is not a stress study.
So delayed enhancement.
Right. So here you want to look at delayed enhancement because what are you looking for? You're looking for infarction, right? Because at rest, this person has a defect. Now, hibernating myocardium can also do that, right? Can also give you a wall motion defect. So that is another consideration where the stress study might be important. But here's your delayed enhancement. What does this show? Yeah, so we can see that there's delayed enhancement along the distribution of the LAD, pretty large amount of delayed enhancement along the distribution of the LAD. It kind of wraps around the apex too, okay? But what else can you say about this infarct? There's microvascular obstruction, so you can see these darker areas here within the infarct. So what does that mean? What does that tell you about the infarct? What does it mean? If we see microvascular obstruction in an infarct, what does that tell us? It's acute, right. So this is an acute myocardial infarction because it's demonstrating microvascular obstruction, right? So what happens with myocardial infarction is in the beginning, if you have an acute obstruction of a vessel, you will have ischemia, okay? But then you start to develop necrosis. The infarct starts to progress from the endocardium towards the epicardium. So at 40 minutes, it can involve partial thickness of the endocardium. You can see what happens at 3 hours, and then you can see what happens at 6 hours. You can go all the way through till you have a full thickness infarct. This is why in patients who might be having a myocardial infarction who present an emergency, it's very important to get them revascularized as soon as possible because this infarction wave progresses from the endocardium to the epicardium, and you'd want to intervene as early as possible to revascularize before you get progression of the infarction through the myocardium, through the thickness of the myocardium. So, yeah.
Just a question on that, the delayed enhancement demonstration. The microthrombus, that's the acute infarct part, but the delayed enhancement that happens in this case, is that just because, I guess the supply is slowed down, and then you have other, like...
No, the delayed enhancement is from leakage of gadolinium because you have cell death. So when there's cell death, there's damage to the tissue, and that causes an increased amount of gadolinium in the interstitial tissues there, in the extracellular tissues. Okay, and so that's why we see the delayed enhancement. The microvascular obstruction is because that's the core of the infarct where the capillaries are thrombosed, and it doesn't allow the gadolinium to get in there at all.
Okay. Yeah, and the normal myocardium is, the enhancement is past that area already, like if the gadolinium is washed out, right?
Well, the sequence is done. Remember, we do this with an inversion recovery sequence to suppress the normal myocardium, right? So there is going to be some gadolinium within the normal myocardium, but the sequence is set up to suppress the signal from the normal myocardium. But you're right, the washout from the normal myocardium is faster than the washout from injured myocardium, okay? So the initial bolus of gadolinium is already washed out, but it hangs around here because it's leaked into the interstitium, okay?
Thank you so much.
So normal myocardium takes up the gadolinium quickly and then washes out the gadolinium quickly. With infarcted myocardium, there can be delayed uptake, but the washout is also delayed. So when you image at about 10 minutes after you're given contrast, there will be more gadolinium in injured myocardium than there is in normal myocardium. And then we set up the sequence to suppress the signal from normal myocardium, so we'll see that difference in enhancement, okay? Now, whether it's an acute infarction or a chronic infarction, both of these will give you myocardial delayed enhancement. So here you have ruptured cell membranes, and you will have gadolinium leaking out into the tissue there, into the extracellular space. With a chronic infarct, it converts to scar, and scar does enhance, does hold on to gadolinium. So with a chronic infarct, the delayed enhancement that you're seeing is due to scarring, whereas here it's because the gadolinium is leaking out into the extracellular tissue. So it's the same patient, whether it's an acute infarct or a chronic infarct, both of these will give you enhancement when you do myocardial delayed enhancement imaging. So here's that patient with the acute infarct. You can see the microvascular obstruction here acutely on the two-chamber view and also on the short axis view. But 6 months later, all of this is converted to scar. So we no longer see the microvascular obstruction. What we do see now is the delayed enhancement from the scar tissue that is formed within the myocardium. Another example, acute infarct here. On the short axis view, you can see the microvascular obstruction, large area view, acute infarct here, and also on the long axis view, the two-chamber view. And then here, though, 6 months later, all of that enhances, but you no longer see the microvascular obstruction. So here's a patient who has had an infarction. Is this patient a candidate for revascularization? We see that there's delayed enhancement here along the endocardial surface. So is this a patient for revascularization? How do we decide what criteria do we use? So the idea is this patient has had an infarct, so the supply to this myocardium is compromised, okay? There is still some viable myocardium there, right? Because the delayed enhancement does not involve all of the myocardium in that region. So is this patient a candidate for a revascularization procedure? And who wants to talk about it?
It walks less than 50%.
Right, so that's the criteria that you use. So the criteria that's used to decide, so this is a viability study. We're trying to decide how much viable myocardium does this patient have. So revascularization is only helpful if you have a sufficient amount of viable myocardium. If there is not a sufficient amount of viable myocardium, then revascularizing doesn't help much because you're just revascularizing infarcted tissue. So the criteria is 50%. If the amount of delayed enhancement is greater than 50% of the thickness of the myocardium, then too much myocardium has died. And so revascularizing that does not result in a significant recovery of function. If the amount of enhancement is less than 50%, in this case, it's certainly less than 50%, then the patient would be a candidate for revascularization because all of this area that might be ischemic, revascularizing that might improve or potentially could improve the patient's cardiac function. So that's the rule that we use, the 50% rule. Okay? Now you can combine first pass perfusion with delayed enhancement. If you have an ischemic area on your first pass perfusion, that will show up as this decreased area of perfusion. And if it is from infarction, right, then that will give you myocardial delayed enhancement. Ischemia without infarction does not give you delayed enhancement. So delayed enhancement is an indication of dead myocardium. Right? So here's a patient who has a sizable infarct. What's the distribution? LAD, right? You can see it involves the anterior wall, wraps around the apex, anterior wall here on the short axis view, and the septum. In this case, another patient who has delayed enhancement here on the short axis view. And then you can see here also on the full chamber view, what is the distribution of this infarction? Circumflex, right. So this is an infarct along the distribution of the circumflex coronary artery. And what's the distribution of this one? Distal RCA or PDA, right? So it involves the distal RCA. Here you can see it involves the interventricular septum, the posterior portion of the interventricular septum, and then it goes on here to involve the dependent wall of the left ventricle. So this is the distribution of the distal right coronary artery, okay? Now what's different about this, and what can we say about this patient? Well, so it seems like it's a weird distribution for this infarct, right? So it involves here the lateral wall, but also involves the posterior wall. Is there a way you can make it one distribution?
They're left dominant.
Yeah, it's a patient who has left coronary artery dominance. So in a patient with left coronary artery dominance who has an infarct in that territory, that would involve the lateral wall and also involves here the posterior wall of the ventricle. So this is a patient who's left coronary artery dominant, okay? All right, so when we're looking at acute infarcts with MRI, there are the different zones that we can see. So there will be areas that are bright on T2-weighted imaging. That involves the edema. The areas that enhance, that's the infarcted tissue, okay? Now we've talked about it, when you have an acute infarction, you might have an area in the center that does not enhance. That's microvascular obstruction. So you'll have an area, you might have an area in the center that does not enhance, okay? So that's an area of microvascular obstruction. What do we do here? Auto power off, turn on. Okay, keep our TV on. So the area here in the center that does not enhance is the region of microvascular obstruction. The region around that that does enhance, this is infarcted myocardium. And then adjacent to that, you may have a region, or you will have a region that is bright on T2-weighted imaging, but is not enhancing on your delayed enhancement. So this area is edema. That still contains viable tissue. That's considered the area at risk. So that is ischemic tissue that is still viable, but that's the area at risk. There's edema in that region. Okay? So the area at risk is kind of important. It turns out the larger the area at risk is, the worse the prognosis for the patient. So in a patient who's had an acute myocardial infarct and survived, what is usually the cause of death initially after the infarct? Arrhythmia, right. So it's the area of risk. The larger that area of the risk, that is associated with a higher risk of arrhythmia that can lead to death for the patient. Okay? So when we look at MR then we can have the microvascular obstruction here, which is the dark area. Around it, the bright area represents area of infarct. Of course, the microvascular obstruction is also infarcted. Right? And then when you look at T2-weighted imaging, this area around here might demonstrate edema, and that would be the area at risk, okay? The peripheral zone. So here, MDE, it shows our partial thickness infarct along the endocardium. But when you look on your T2-weighted image, you see that there's more edema here, okay? Then you can account for just looking at your areas of enhancement. So that is your area at risk. Now, if we look at what happens to an infarct with MR over time, it turns out that the infarct size, that area of enhancement, decreases a little bit over time and tends to stabilize at about 7 days. And you will see the edema initially, and then the edema goes away gradually. So if we look at the acute infarct, there's the microvascular obstruction here. Here's the acute infarct around it. So 1 week later, you can still see the area of microvascular obstruction. There's the infarct around it. 1 month later, the microvascular obstruction doesn't show up as much anymore. You can see the infarct itself, the areas of enhancement look like it's a little bit smaller. So this is when it tends to stabilize in terms of size. 3 months later now, it's all completely converted to scar tissue, and so that's what we're seeing here as the area of enhancement. When you look at the edema, we see the edema acutely. 1 week later, we still see some edema, but then once we're out here at 3 months, we no longer see edema there. So the edema is associated with the acute infarct. Okay, so wall motion. So let's talk about, how we judge, or the things we look at when we judge wall motion. So for this particular patient, right, what's the problem with the wall motion?
Anterior septal wall is hyperkinetic.
Anterior septal wall, right, and the septum. And so here, when we look our delayed enhancement, you can see that all of that correlates with an infarct at the patient. And you can also see that the myocardium is thin in this region, which tells you that this is a chronic infarct, right? Thin myocardium is also associated with a chronic infarct. And so you can see that the infarcted zone here corresponds nicely with the area where you have the abnormal wall motion. Now, when you're judging wall motion, the terms that you'll use: hyperdynamic, normal, mild hypokinesis, severe akinesis is when you have no wall thickening, and dyskinesis is when the wall actually bulges out during systole. Instead of moving inward, the wall bulges out. What can give you hyperdynamic wall motion?
Pericardial effusion.
No, not a pericardial effusion does not give you hyperdynamic wall motion.
Hypertrophic cardiomyopathy.
Yeah, hypertrophic cardiomyopathy is associated with hyperdynamic wall motion, yeah. And then hyperdynamic states too, I guess, like anemia, or if the patient is given any kind of stimulant, will also give you hyperdynamic wall motion. So you can look at wall motion also with CT. So here on this, this is a volume rendering, kind of a 4D ventriculogram, and you can see here as we're looking at the left ventricle, moving it around, here you can see that there's dyskinesia in the region of the anterior wall. So that's the distribution of the LAD. So CT, if you've done retrospective gating, you can also use to evaluate wall motion on your CT scans. Here's another example with CT. So here we're looking at right coronary artery territory. Down here along the inferior wall is where you have the abnormal wall motion in this case. Okay. So complications of ischemic heart disease. So what kind of study are we looking at here? Well, what kind of study is this? That's the easy question. Yeah, this is a CT. You can see what the bones look like, right? So that's a CT scan, full retrospective gating. So here's the left ventricle. So what's abnormal? Yeah, you can see that there's an aneurysm here at the apex of the left ventricle. So you can see it nicely here on your volume rendered views, and then here on the 2-chamber view, 4-chamber view, you can see where it kind of bulges out. So there's an aneurysm here at the apex of the left ventricle. So these aneurysms are usually secondary to MI along the distribution of the LAD, right? As a sequela of that, what might you see on the plain film?
Calcifications.
Calcification, right. So calcification along the apex of the ventricle, right? So that's a sign of a calcified old aneurysm, which is usually sequela of infarct along the distribution of the LAD. So you can see this calcified aneurysm here at the apex of the left ventricle, okay? Anything else you notice about this aneurysm? There's thrombus, right. This dark area within the aneurysm is not myocardium, okay, that's thrombus. So these aneurysms are also susceptible for developing thrombi. So this patient has a thrombus here in the apex of the left ventricle, okay? So these are true left ventricular aneurysms. So these result from fibrous replacement of infarcted myocardium. So most commonly they involve, especially the apex of the left ventricle associated with infarcts along the distribution of the left coronary artery, especially the LAD. These don't rupture, but the stasis of blood within these regions can result in mural thrombi that because of the abnormal wall motion. So whenever you find a case with calcification along the apex on CT or an aneurysm at the apex of the ventricle, look carefully for thrombi, because thrombi are very commonly associated with that. So calcification at the apex of the heart, you can see that on the plain film. So that's an indication of an aneurysm. So these will have a wide mouth and they commonly calcify. Easy diagnosis with CT, of course. Here's a lateral plain film. Often these are easier to see. The calcification is easier to see on a lateral projection. You can see the calcification at the apex. And then on the CT, whenever we see calcification of the myocardium, it's an indication of a prior infarct. Okay. What do we have? What do we see in this case?
Renal infarct from thrombus.
Yeah, so in this case, you can see that the patient has bilateral renal infarcts, right? Where's the thrombus?
Left apex.
Yeah.
Heart.
So there's filling defect here at the apex of the left ventricle, right? You can see that the apex is thinned. So this is from a prior myocardial infarction. The patient has developed thrombus in here, and this calcification is actually calcification in the thrombus. So chronic thrombi can also calcify. And one of the complications of patients who develop thrombi within these aneurysms is emboli from the thrombi, which can result in strokes, which can also result in infarcts. Here there's infarcts to the kidney in this patient. Okay? So here you can see the volume rendered views showing you the infarcts here at both kidneys in this patient. And here's a volume rendered view showing you the thrombus at the apex of the ventricle. All right, so this patient shows up in the emergency room with this chest radiograph, right? So the chest radiograph shows bilateral consolidations, bilateral effusions. Of course, they send them to CT to rule out pulmonary embolism, right? And the CT scan shows what?
Subendocardial hypoenhancement.
Yeah, so this is not a cardiac CT. This is a CT that this patient had for other reasons. And you can see this subendocardial hypoenhancement here along the apex and along the septum. How do you interpret that? What does that mean for this patient? What's happening?
Nerving the MI.
Yeah, the patient's having a myocardial infarction and is in pulmonary edema or in heart failure because of a myocardial infarction. Okay. This is 3 days later. So of course, 3 days later, patient gets another CT. What's happened now?
Filling defect of the left ventricular apex.
Yeah, so now there's a filling defect here at the apex of the ventricle, right? So that represents a thrombus. So it's very common even in patients who, after they've had acute infarctions because of wall motion abnormalities. So a complication of this is also for patients to develop thrombi, intracavitary thrombi. So this is a thrombus here at the apex of the ventricle. And again, you can kind of appreciate the decreased perfusion here, along the myocardium there, okay? Okay, so if I tell you that this patient also has a history of myocardial infarction, what's peculiar about the chest radiograph here? Is there anything abnormal about the cardiac contour? Yeah, so there's enlargement here along the left ventricle, right? But there's also this funny looking bulge, right? See that bulge? And on the lateral view, here it is, right?
Left atrial.
Well, so if I tell you, right, so if I tell you that the patient has a history of infarct, right? And there's a bulging here related to the posterior wall of the left ventricle. So here you would be concerned about what? And what does the CT show? So how do you know that's a pseudoaneurysm?
Location.
Well, what's more important than that? The neck size, right? So the best way to differentiate a true aneurysm from a false aneurysm is the size of the mouth, right? Can you see the mouth in this case?
Really?
Not really, it's so small you can't even see the mouth, okay? As opposed to a true aneurysm has a wide mouth. So what is this out here? What is this?
Is that the
Cardiac?
That's pericardium, right? So what a true aneurysm is a contained perforation of the ventricle. So this patient has perforated the ventricle as a complication of their infarct, and what's containing everything now is the pericardium. So the treatment for this is surgery, right? Because the risk is rupture, and of course the patient will exsanguinate, okay? So the difference between true aneurysm and false aneurysm, a false aneurysm is a perforation of the myocardium, and it's contained by pericardium. So these are surgical emergencies if it's acute, right? And how do we differentiate them? Well, we look at the mouth. That's probably the best way to do it. Wide mouth is true aneurysm, narrow mouth is associated with false aneurysm. In this case, you can actually see the myocardium, right? So you can see that the myocardium is here, and so this has to be pericardium. So false aneurysms, so these usually occur after RCA or circumflex infarcts. So usually involve the posterior, lateral, posterior, or diaphragmatic wall. So if there's a bulging from the posterior wall or inferior wall of the left ventricle in a patient who's had a myocardial infarct, and there you might be concerned about a false aneurysm, as opposed to the apex, which are associated with true aneurysm. They require surgery, small ostium. If the ostium is less than 1/2 the diameter of the widest part of the aneurysm, then you might be dealing with a false left ventricular aneurysm. So bulges like this along the posterior wall of the left ventricle in a patient with a history of recent myocardial infarction, so that is concerning then for formation of a false left ventricular aneurysm. Here's another example. This is with MR. So you can see that there, the mouth is very narrow. All of this out here is pericardium, okay? And these can also contain thrombi. So thrombi can form within these false aneurysms. Okay, so this is a 47-year-old woman who has heart failure, and patients, again, another patient who's had a recent myocardial infarct. What kind of view is this? First, what kind of study? What kind of study is this?
CT.
Yeah, so this is retrospective gated cardiac CT. What kind of view is this? Yeah, it's a left ventricular outflow tract view. So this guy is left atrium, this guy, LV over here. That's the aorta. Okay. So what do we have? What looks peculiar? Before you give me a diagnosis, tell me what looks peculiar. Yeah, so there's this funny looking hypodensity here in the left ventricle, right? That just seems to be floating around in there, right? So one possibility is maybe that's a clot. Certainly, clots can be associated with infarct. Maybe that's a thrombus. But what do you notice about this that's really strange?
It's fixed.
Yes, it's fixed.
Yeah, it's attached to the valve. And what's attaching it to the valve? The chordae tendini. So what do you suppose this is then?
Papillary muscle rupture.
It's a rupture of papillary muscle, right? So this is a rupture of a papillary muscle. So this portion of it is sitting here attached to the chordae tendini. So what complication would ensue in a patient who has acute rupture of the papillary muscle? Mitral regurg, acute mitral regurgitation, yeah. And that can result in a worsening of heart failure in patients after infarct, this acute mitral regurgitation. So the chest x-ray might look like this. What's the finding on the chest radiograph? Yeah, so consolidation or pulmonary edema kind of worse on the right side, especially in the right upper lobe. And that can occur because the jet from the mitral regurg can be directed towards the right upper lobe pulmonary artery. So asymmetric pulmonary edema can occur in these patients where it's worse on the right side than it is on the left side. Doesn't have to be, they can just have regular pulmonary edema, but this can be associated with acute rupture of the papillary muscle from infarction. So name these structures. First, what do you call these? They have names, right? Which is which?
Posterior medial and anterior.
Yeah, so that's the anterior and that's the posterior papillary muscle. Now, which one of those is more likely to rupture after myocardial infarction?
Posterior.
Posterior why? So the anterior one has a dual blood supply, right? So the dual blood supply to the anterior one is LAD and circumflex, right? So we have here the anterolateral papillary muscle there, that's supplied by the LAD and the circumflex, so that has a dual blood supply. The posterior medial papillary muscle, right, that might be supplied by the distal right coronary artery or the circumflex if it's dominant, but especially if it's supplied by the distal right, then that has a single blood supply. So that's the one that's more likely to rupture in a patient who's had acute myocardial infarction. Okay? So this tends to occur within 5 days of a myocardial infarct, especially if it involves the posterior wall, posterior medial papillary muscle, as we've talked about, why that tends to be involved more often. And it can result in intractable pulmonary edema because of the acute mitral regurgitation is not well handled, that's not well tolerated. And these patients can have asymmetric pulmonary edema, worse on the right side than the left, especially in the right upper lobe. Acutely, there won't be any change in the size of the heart because it's an acute mitral regurg as opposed to chronic mitral regurg. Here's another example. This one has kind of diffuse pulmonary edema. There is pulmonary edema bilaterally, but it's worse on the right side, which can occur with acute rupture of papillary muscle. Okay. Now, another complication of infarction can be mitral regurgitation from papillary muscle dysfunction. So if the infarct involves the papillary muscles, then the papillary muscles also don't function properly, right? Part of the function of the papillary muscles is to keep the mitral valve, from moving too far posteriorly to prevent mitral regurg. So papillary muscle dysfunction can also result in mitral regurgitation. So that involves usually the posterior medial papillary muscle from ischemia, okay? And you might see some mitral regurgitation associated with that, right? So this can also be a complication of infarction. So here's a 71-year-old woman after a myocardial infarction. You can see again there's asymmetric pulmonary edema here. It's worse on the right side, but this was from papillary muscle dysfunction as opposed to rupture, and her echocardiography showed severe mitral regurgitation from the papillary muscle dysfunction associated with the infarct in this case. Okay, so there's another patient. This patient had a myocardial infarct about 1 week ago. What kind of study?
Cardiac CT,
So it's cardiac CT. And what kind of views do we have?
4-chamber. and
So
short
here's a
axis.
4-chamber view, and then here's a short axis view. Right. So what do we see? What do we see that's abnormal in this case?
Defect in the interventricular septum.
Yeah, so here there's a defect in the interventricular septum, right? So is this a congenital VSD or is this something else?
Ventricular rupture.
Yeah, so this is rupture of the interventricular septum, which is another complication that can occur from acute myocardial infarction. Okay, this also can result in pulmonary edema and failure acutely because of the rupture of the septum. So this is not tolerated. Acutely, it's not well tolerated at all. So rupture of the interventricular septum usually occurs within 1 week of a myocardial infarction. Low percentage, about 1%, usually involves the muscular septum near the apex, that's the LAD territory, more common than the PDA territory. 75% are associated with left ventricular aneurysms. So 50% can die within 1 week, 90% in 1 year if these are not treated. So a new systolic murmur after a myocardial infarction, biventricular failure after myocardial infarction. So all of these can be indications that you might have a rupture of the interventricular septum there. Okay? So rupture of the septum, usually these patients go into CHF with pulmonary edema, so that's going to overshadow the findings of the left to right shunt. So we will see pulmonary edema, effusions, left ventricular infarction. So these are all things that we might see with rupture of the interventricular septum. Okay, so those are our